NEI Spring Congress attracts the world's best faculty to teach clinicians like you psychopharmacology essentials according to adult learning principles. Register today to join leading experts at our 8th annual event, being held May 8th through the 10th in person in Philadelphia, where I was born and raised, and via simulcast online. Use discount code NEIPOD25, that's NEIPOD25, to save $100 on your registration at NEI.global/SP Congress 25F. That is NEI.global/SP Congress 25F. Discount good on new registrations only.
Welcome to the NEI Podcast. In this very special episode, we feature highlights from the PsychopharmaStahlogy Show, hosted by Dr. Andy Cutler and featuring Dr. Stephen Stahl. We will share clips from the most popular episodes throughout the series. Enjoy the best moments. First, we have a segment from episode 187, Treating ADHD Across the Lifespan with Dr. David Goodman.
Let's talk about women versus men. Women are the group that is fastest growing as far as being recognized and diagnosed with ADHD right now. Women over the age of 19 is actually the fastest growing group. Let me ask you a couple quick questions and set you up before we get into this. And the first one is, you alluded to this earlier, that in children, there's a 3-to-1 ratio, boys to girls being recognized with ADHD, but it approaches 1-to-1 in adulthood. Do you think ADHD is really more common in boys, or do you think it's a recognition issue? What do you think is going on?
I think it's a recognition issue. I think it's the symptoms that present that people observe. It's the difference between the observer making a diagnosis, if you will, of disruptive behavior that's problematic versus older in life where you realize you're not functioning at the level that your peers are functioning. And so the referral for children is often by a parent or a teacher. The referral for an adult is often themselves. So that's why the girls tend to increase in the diagnosis as the environmental demands increase and their ability to compensate is compromised. Now, the risk factors for not getting diagnosed are being bright, having a structured environment, / a partner, or being female.
Interesting.
And so now I'll add a comment that's going to be controversial. And the controversy here is the delay in making a diagnosis in women a sexist bias? In other words, the ascription of psychological symptoms for women is different than the ascription of psychological symptoms for men. And it has been documented that women have a delay in getting certain medical and psychiatric diagnoses over their male counterparts.
Well, I've had a patient of mine who was diagnosed in college, a young lady, who said that her diagnosis during childhood, because she wasn't climbing on desks, was that she was blonde. And she was very, very upset about that, and felt that she was just a space cadet, just a crazy girl, just to be dismissed. And that is an index of suspicion that should arouse the thought of ADHD in a young woman, girl, as opposed to, they don't crawl on desks and push guys around, and they're not hyperactive as much. I mean, not necessarily.
And that's a great point. I had an airline stewardess who cried again when I make the diagnosis and treated her, and she said, I'm crying because my whole life people thought that I was blonde and stupid.
Yeah, exactly.
And she was not.
Yeah, boys tend to, and males tend to act out and externalize. Women tend to internalize. And there is, of course, a lot of social stigma and social norms of behavior and this kind of thing. So I appreciate you saying that. It is potentially controversial, but I think it's appropriate to say. I'm wondering, David, too, how much of this relatively recent rise in the recognition in women had to do with COVID? Frankly, women, as we know, wear many hats. They have many things going on. And with COVID, now all of a sudden, Kids are home from school. They're not going to the office. Routines are disrupted. There's just more on their plate. Do you think that played a role?
I think COVID did play a role in increasing the diagnosis of ADHD.
Mm-hmm.
I remember I had a woman who said her daughter must have ADHD, but the father absolutely refused. The mother and father were separated.
Mm-hmm.
And during COVID, the daughter had to spend much more time with dad.
Yeah. And
at the end of the week, dad called mom and said, would you get this kid evaluated for ADHD?
Exactly.
So for years, he had put off getting the diagnosis. I do think that the absence of structure
mm-hmm.
for many ADHD individuals who no longer had to go to work
mm-hmm.
and be in a work environment, they now had to be at home and structure themselves, really, really was problematic.
Yes.
However, I've also had people who say, thank God I don't have to be in the office.
Right.
I'm not distracted.
Right.
I can sit in a room with no windows, no noise, and be highly productive.
Right.
So I think it was very much dependent on what the demands were, what the environment was, what your social support was. Did you have a spouse? Did you have a partner? But definitely, and we know from prescription rates, the prescription rates, which typically had been about 4 or 5% annual growth, jumped up over 10% from 21 to 22. And that's documented by the FDA.
Yeah, absolutely. If I could go back to your comment earlier about the father spending more time, our friend Greg Mattingly that Steve and I did a podcast with just recently, he likes to say with kids, the calls tend to go to the mom from school when there's a problem. And he'll tell them, just start having the calls go to dad and we'll see how quickly he agrees with the diagnosis and says we need to get help. Okay, furthering our discussion here of women. First of all, David, I have to commend you. You gave a stellar talk at the NEI Congress a couple years back on what's known about ADHD in women and reviewed the literature. And so you're a perfect person to talk to about this. We talked about how ADHD can present differently, certainly, but what about the hormonal changes? You mentioned this earlier. How does that impact both the presentation and, of course, the treatment?
So for those listeners who are really sparked by this, I would strongly encourage you to take advantage of your NEI membership and go back and listen to my lecture about a year ago that was delivered at Synapse. It really covers it from soup to nuts. Let me just focus on one that is particularly pertinent, and that is the women in perimenopause. So in perimenopause, where the estrogen levels are dropping, women will contemporaneously complain of cognitive changes. And for a long time, it was dismissed. Again, I think it was a sexist bias, but it was dismissed. The literature was equivocal at best. But it's now become clear that estrogen is pro-cognitive, that there are estrogen and sex hormone receptors in the prefrontal cortex through which many of the networks travel through. And so in perimenopause, as the estrogen decreases, women complain of this. Now, if you have somebody who has ADHD who starts complaining about a decline in cognition, is it because their ADHD is getting worse? Or is it because the cognitive effects are being worsened by a decline in estrogen? Depending on what you decide will determine what you do pharmacologically. Do I increase my ADHD medication? Or do I send the woman to an OBGYN to have an HRT trial for 3 months to see whether that corrects? Now, whether they're on HRT has other factors to be considered. If you're a post breast cancer patient, for example, then there are considerations as to what that is. But it's clear that the ADHD woman going into perimenopause will complain cognitive ability is worse. Now, if you've been diagnosed with ADHD, what I've just laid out is pretty clinically clear. If you've never been diagnosed with ADHD and now you come in complaining about cognitive decline over the last few years and you don't assess this woman for ADHD, you may go in a different direction and miss the opportunity to treat the ADHD rather than simply put the woman on HRT. So that's a very important clinical distinction. And having said all of that with great confidence, is there a lot of research? No. My opinion here has been cobbled together from whatever the prevailing research exists and having treated patients for the last 37 years. But it is interesting, and I think the next clinical frontier of ADHD is in older adults, both for women, for their hormonal issues, as well as for men. And if you want, at some point, we have the opportunity to talk about older adults going from ADHD to MCI to early dementia,
right,
and how you sort out the differential diagnosis. And then how do you decide what the concurrent comorbid aspects of that, and how do you construct your pharmacologic algorithm to take into consideration all of those presenting disorders?
Well, I just was wondering as you're talking whether you feel that you can optimize the treatment of ADHD in a postmenopausal woman in the absence of HRT. Does dopamine work as well when hormones are low? And then a kind of corollary to that is that the fluctuating hormones occur in perimenopause. Do you find that ADHD fluctuates as the hormones do, and that the stimulants help that?
So the cognitive ability definitely declines with declining estrogen in the ADHD individual. And then the question is, do you go to HRT or do you go to stimulant? I will often go to HRT first for 3 months to see whether that works. If that's substantially helpful, I mitigate against increasing stimulant medication. If they go to HRT or they're told that they cannot be on HRT at all, then I'll go to increasing the stimulant medication gingerly while following cardiovascular vital signs. And that does improve it. This ties into, we're talking about declining estrogen physiologically, but we also have declining estrogen by prescription, and that is in women with breast cancer to whom we prescribe estrogen-reducing compounds. What happens cognitively? It appears that if you're using tamoxifen, anything that interferes with the estrogen receptor or estrogen synthesis also compromises cognition. So there is a body of literature that's looking at that. Now, if you have somebody with ADHD breast cancer who goes on tamoxifen, they're going to complain their cognitive ability is worse. Now, what do you do there? They can't come off the tamoxifen. In those patients, I've actually increased the stimulant, and it's been helpful. Is there any literature published on what I just said? Not a single paper. But these are the clinical issues, Steve and Andy, that our patients want answered.
Well, how much do you think chemo brain is ADHD exacerbation?
So you have to decide whether ADHD predated the chemo brain. It's a trajectory, not a cross-sectional symptom checklist. So you can have people who don't have ADHD and have chemo brain, or you can have people with ADHD and chemo brain that worsens their cognitive ability. And again, just like in the perimenopausal woman, do you go to HRT? Do you stop your tamoxifen, or do you increase your stimulant medication? There's not any literature to give us clinical guidance, and so you have to construct your own pharmacologic algorithm and decide what the target symptoms are over the course of time, which speaks to why it is so important for patients to have continuity of care with a single provider who knows how to track this. If you're seeing a different clinician every time you go to a clinic, it is very hard for them to come up with a plan to treat this.
What about, David, you're sort of alluding to this notion that people with ADHD have higher risk for dementia, or that it somehow leads to dementia. I realize we talked about how it can be hard to tease that out, but do you believe there's really an association there, or what do you think is going on?
That's interesting, because we call ADHD a neurodevelopmental disorder, and there's a body of literature that's questioning whether it's not a neurodegenerative disorder. So there's some research that looks at ADHD associated with Alzheimer's, with Parkinson's disease, and with Lewy body. The one piece of evidence that's probably the strongest is the ADHD association with Lewy bodies at a 5-fold higher risk.
Wow.
But I think that's only 1 or 2 studies, so let's not take it to the bank. But we should be mindful in following the ADHD patients when they get older, whether they're at risk for. Now, when I said earlier that I have a patient with I've had several patients with ADHD who developed MCI and then went on to early dementia, I'm not making association between the ADHD and the dementia. I am highlighting the clinical challenge of deciding what cognitive symptoms constitute the ADHD, what clinical symptoms constitute the MCI, and what symptoms constitute the dementia. There are neuropsychological differences in the cognitive abilities of each of these people.
Right.
For example, an ADHD individual is not likely to have problems misspelling words unless they have a learning disability,
Right.
or difficulty finding words when they're speaking. The MCI patient is probably going to have difficulty finding words and misspelling. The Alzheimer's patient is now going to have difficulty keeping track of their thought in mid-paragraph or mid-sentence. So these are the subtle cognitive differences. And then for those patients, do you continue them on their stimulant medication?
Right.
Is that really helpful? And or do you go to a donepezil, for example, and can you use the two together?
Right.
You know, I'm so passionate about this area because the absence of literature is so stark that we don't have clinical answers and guidance on this.
Next, we hear from Dr. Michael Cummings in episode 162, Management of Complex Treatment-Resistant Psychotic Disorders.
What would you say in patients with complex psychosis, what are some of the most challenging components to treat and how are they addressed in the book?
There are a multitude of them. I often tell our residents and medical students that our modal patient is somebody who had severe childhood adversity, grew up to develop a psychotic disorder, often came from a family of psychotic disorders, which was then complicated by multiple head injuries, substance use disorder, development of a personality disorder. The first thing that we were attracted to in treating this population, largely because we work for state hospitals, was violence and aggression. That essentially is the reason that people wind up in state hospitals. Is it isn't safe for them, either for the patients or for society, for them to be in a less controlled environment until their illness is better managed. The complexity arises both from treatment resistance, and it's been estimated that about 30% of schizophrenia spectrum disorder patients are treatment resistant through current consensus criteria, House et al., which were derived from the Kane criteria. In our hospitals, that number is about 2/3 are treatment resistant. So you have very difficult psychotic illness that is punctuated by a lot of comorbid disorders as well as resistance to treatments that would work much better in the community.
Well, I think you've really elaborated well when you talk about your typical patient, all of the different aspects here to consider. You're talking about, obviously, trauma, life adversity, probably genetics, substance abuse, head injuries, so organic issues, medical issues. It's a lot to sort out, isn't it?
That's an incredible amount to sort out.
What happened is that everybody sees these patients who treat psychosis. But as Mike said, I really like that, his idea that the state hospitals are a vast laboratory. Be modest and say we don't know anything more than anybody else, but we see it so often that we actually make all the mistakes, figure it out, and then can tell people what to do. But what happens is that it's not evidence-based medicine, it's medicine-based, practice-based evidence. But we've done it over and over again. So many people will see these, but not frequently. We have 40 million people in California. That would be between 400,000 and 800,000 schizophrenics. These would be the 1%. The top 1%, if you will, of the most violent, difficult patients are 7,000 patients in the hospital. We eventually figured out how to do it over and over again. That's what the book's about.
Yeah, I see. Wow. Michael, you mentioned aggression and violence. What are the steps for sorting that out and then managing this in your patients?
Step one, is usually the case in medicine, is essentially diagnosis, not in this case of their mental disorder, but of the violence itself. That is, what is the origin of their violent behavior? Basically, a group at New York State Hospital nicely figured out that most violence in a state hospital system and a psychotic disorder arise from three sources. The psychosis itself, usually a combination of paranoia, and anger, or from associated antisocial behavior. A fair number of our patients are comorbid for antisocial personality disorder, so they may have predatory violence. But a number of our patients, in fact, the majority, 59% of the violent episodes, at least according to one of our colleagues, Dr. Morissette's survey in the state hospital system, 59% were impulsive violence. That is, failure of top-down regulation of violent and aggressive impulses. So the first step is to decide where the violence is coming from, and then to begin to target treatment toward that source. We do the very best, of course, with psychosis because we have good tools. Only 17% of our persisting violence in the state hospitals arises from psychosis because we're good at getting that under control. Predatory violence is mostly an issue for custodial measures, some psychosocial treatments. Impulsive violence is where we really have a long way to go in terms of giving people better control over their impulses. And indeed, we do talk about that in this, as you might guess, with treatment resistance and impulsivity being very prominent issues. We are very pro-clozapine because indeed it has exhibited both superior antipsychotic effects in a treatment-resistant population and also has demonstrated an ability to improve executive functions and to reduce violence that arises from impulsivity. So we've managed to increase the usage of clozapine substantially over the last decade. Frankly, clinicians were very fearful of using clozapine. We've done multiple lecture series, supported people, literally went out and held their hands and said, yes, you can do this. And we've roughly doubled the rate of clozapine use in the state hospital.
Yeah, I would think, especially in a hospital environment where you have a lot of the supports needed and access to blood drawing and things like that.
Yes.
So I'm surprised to hear there was some reluctance.
If we recommend, and certainly what the literature supports, is that if somebody fails 2 good solid trials of antipsychotic treatment with antipsychotics from different classes, it's time to move on to clozapine. Because the odds that person is going to respond to anything else is 5% or less, whereas their odds of responding to clozapine are somewhere between 40 and 60%. But our average patient who's admitted to the state hospital has had 7.3 medication trials.
Oh my
People
goodness.
stick with what doesn't work because they're fearful of clozapine.
Yeah. Yeah, I used to be the medical director of a clozapine clinic 20 years ago, and I certainly saw for myself what it could do, and the two sides, the good sides and the bad sides of it. But I think on the whole, we'd all agree the benefits outweigh the negatives. What role would LAIs have in this? Would you consider a patient a treatment failure if they have not had a trial of an LAI?
Very frequently, yes. Probably the 2 classes of medication in our population that we push most strongly are clozapine and long-acting injectable antipsychotics. Even in our setting, the LAIs are underutilized. In fact, that's true of U.S. psychiatry in general. In Europe, the usage rate for LAIs is up around 60%. For people with a schizophrenia spectrum disorder in the U.S., they're less than 10%. For reasons I don't understand very well, people tend to reserve the LAIs as a treatment of last resort when, frankly, I think we should be using them up front. I know that although every single study out there on adherence says that adherence to antipsychotic medications is miserable, even if you give people full credit for 80% of the doses being taken, compliance rates are still under 40%. But every single psychiatrist tells me, but not my patients. And I tell them, no, your patients cheat on you too.
Yeah. Well, and it's interesting. There is data that if compliance falls below 80%, the risk of relapse starts to go up. So even if you're intermittently compliant, that's a problem. Yeah, I agree with you. I feel like you can't really tell that someone's an atypical antipsychotic until they've had a trial of an LAI. And I have some somewhat good news, Michael. The latest data I saw is maybe 10 to 15% of patients are now managed in the U.S. We've had We've had a number of companies, as you know, promoting and educating. And I like to say, for some reason, most of us are trained that you have to earn an LAI by being non-adherent and relapsing, and that just doesn't make sense to me either.
Yeah, whereas if you read this book and some of the articles that we've also published, we suggest that LAIs should be very high up, very early in treatment.
There's evolving data from studies that show, guess what? If you don't treat people, they don't get well. And if you don't treat them and they relapse, they have bad outcomes. And if you don't treat them and they relapse, then you get treatment resistance. And so we have a number of decriminalization programs, and in California, this new CARES report, which is a way to divert people who haven't committed a crime yet into treatment. If you don't treat cancer at stage 1, it becomes stage 4. If you don't treat psychosis at stage 1, it becomes stage 4. That's the violent 7,000 patients that we have in the hospital. So how do you treat them? It's with the LAIs, particularly after they leave the hospital.
Yeah, I had a professor in my residency who used to say, never let a patient stay psychotic because psychosis is bad for the brain, which has always stuck with me.
Very, very true. I was impressed in looking at the imaging literature that obviously after a first break, the response to an antipsychotic is typically wonderful, greater than 90% response rate. By 5 years after onset of illness, that's typically down around 50%.
Wow.
And that seems to be correlated with, frankly, loss of brain. People who have recurring relapses during the first 5 years of illness lose about 2% of their brain every year. And that's brain that's gone. And I think that shows up. The other statistic that has really stuck with me was a study by Tohanen et al. In Sweden, where they compared LAIs to the same medication, its oral counterpart. The nice thing about the Scandinavian countries is they track people from birth to death. And they found out that the people on LAIs live 30% longer.
Oh my goodness. That's remarkable.
Which is, if I told most people, if you take this medicine, you'll live 30% longer, well, that's a pretty good ad.
That's pretty good. Yeah, his group also has data on decreased hospitalization rates, relapse rates, and a number of other positive outcomes. So I think now the standard of care, the evolving literature really suggests, exactly as you're saying, that we should be using LAIs earlier in our algorithms and give people the best chance. So that's definitely one of the tricks here. You talked about managing aggression. I want to go back to that for a second. Some of us think about using anticonvulsants for impulsivity and aggression. Is there a role for those?
There is, and indeed that's addressed both in terms of an approach to aggression and impulsivity, particularly early in the course of an episode of psychotic exacerbation. In particular, we use a lot of valproic acid. It seems to have a great deal of applicability, particularly in the early days of a psychotic relapse, for decreasing psychomotor agitation and violence. Becomes less important in people without an affective component as the antipsychotics take effect. Lithium also, although lithium's formal data is mixed with respect to pure schizophrenia, but when there is a mood component, which is frankly not unusual in our patients, a large number of our patients are vulnerable to a bipolar diathesis, then lithium and valproic acid become incredibly important. We use very little carbamazepine, the other first-line mood stabilizer, largely because of problems with its side effect profile and, of course, its hepatic induction.
Of course. Yeah, I was going to ask about lithium, so I'm glad you mentioned that, too. I used to use lithium with clozapine when I was running that clinic frequently. Not infrequently, I should say.
We do as well. For lithium, of course, has a specific indication for, aside from mood stabilization, for decreasing suicide risk. But one of our most common uses is to boost the person's absolute neutrophil count. And where we see it used in one of the pieces of advice in the book is in the chapter on treatment-resistant psychosis, is to use it for those people who keep slipping just below the threshold, and then they wind up with 3 times a week blood monitoring, which frankly, over time, that will cause people to not want to take clozapine. So we give them lithium to see if we can get them up above that threshold so that doesn't keep happening to them.
Let's now listen to a clip from episode 227, Underutilized Psychiatric Drugs, Lithium with Dr. Jonathan Meyer.
You know, a lot of people may not realize that lithium has wide-ranging effects, including neuroprotective effects in the brain. Some people may know about the anti-suicide effects, but can you discuss this a little bit further?
Yeah, we've known for decades that lithium had some unique neuroprotective properties, well demonstrated in animal models. It was studied in animals for a number of things: stroke, neurodegenerative disorders, etc. The human evidence really came to fore in the last decade, and there's a wonderful 2020 meta-analysis by Velosa. I won't get into all the mechanisms because lithium clearly is the sum of its parts, but the data is what I want everyone to remember. So this paper, which came out in 2020, the first author is Velosa, Velosa, showed that if you keep older individuals on lithium, for at least a few years, that you reduce their future dementia risk by 49%.
My goodness.
49%. And the important take-home message is valproate had no effect, number one. We'll hear a lot of bad things about valproate. But also, people with a history of mania have 3 times higher rates of dementia than the general population. So it's important to recognize it's a high-risk group for developing neurocognitive disorders, and lithium has an enormous effect.
Now, what doses were being used? Is this therapeutic doses or?
Yeah, these are therapeutic doses. So, and I know why you're asking, because I can read your mind, broadcast your thoughts. There is treatment for that, but that's a different podcast.
Yes, all right.
But the idea is that if you ask me, well, what about micro or low dosing? I can't give you an answer, especially if you're a low-risk population.
Right.
But I think the point is that, when you and I trained, and I still hear this, people get taken off of lithium just because they get older.
Absolutely.
I don't know, Steve, does that seem like a good thing to do?
That sounds like a good time to start it. I mean, I'm hanging on to every piece of gray matter I can at this point in my life. So, yeah. I mean, I don't know, more brains probably better than less brains. So, increasing your gray matter is a good thing.
So, Jonathan, why are people taking them off the lithium then?
It's fear more than anything. It's one reason why Steve and I, kind of got the handbook out there. People are afraid. They understandable. When you get older, you often have declines in your GFR. It's age-related. And there's a concern that people lose their safety margin or that lithium is inherently unsafe. But I think the evidence is to the contrary. Often what does you in as people get older is not the lithium per se, assuming it's being used intelligently, meaning being given once a day, that the 12-hour levels are always in that sweet spot between 0.6 or 0.8, never above 1. Assuming you're doing it that way, the independent contribution of lithium to renal dysfunction is modest. But what often does you in is the comorbidities. It's a group of people who have severe mental illness, bipolar spectrum or schizoaffective bipolar, lots of hypertension, prediabetes, diabetes. That's often the culprit. But to just reflexively take people off because of age makes no sense. All decisions should be made based on GFR, taking into context also the medical situation.
Well, maybe a more responsible message is, of course, as we age, it is possible our renal function may decline, particularly if we have hypertension. So just monitoring the levels, and you might have to adjust the dose. Don't just set it and forget it. I think that's a more responsible message, maybe.
Yeah, absolutely. And another point, which many people don't realize, is as you get older, often your blood-brain permeability barrier changes. And so you may be able to run people as they get into their 60s, 70s, and 80s at slightly lower levels than when they're in their 20s, 30s, 40s, and 50s. So really be mindful of that, especially if the person starts to complain that they're feeling essentially over-medicated. They're getting a tremor, they're complaining of cognitive dulling. Take that as a real complaint that they're getting more CNS penetration of lithium. And maybe this person who's always at a level of 0.75 might do fine with a level of 0.6, 0.55. Do it slowly, do it judiciously, but just kind of keep that in the back of your head that this is something to consider as people get older.
Yeah, Jonathan, when you and I trained, I would dare to say that we were really trained to use lithium. I mean, I know I was, and it was definitely something that I was very positive about. But nowadays, it's not being used as much and probably not nearly enough. Why is that? Maybe historically, what happened that kind of led to it falling out of favor?
Well, there's two trends. One of them was the rise of valproate. It sounds like a sort of a Star Wars movie, the rise of valproate. But that was it. And then number two is the atypical antipsychotics. And there's many people who say, well, these agents have anti-manic properties. A couple of them also have antidepressant properties. Therefore, they must work the same as lithium. But I'm pretty sure, Steve, that they don't have the same impact on second messenger systems or the same clinical profile, even though they may exhibit anti-manic or antidepressant properties.
Absolutely. And I think the other thing is you can be gentle with lithium and not drive it hard, which is sometimes how we did it. I mean, we had, let's give it twice a day and slam them twice. And let's also give it, so who cares if once in a while it goes over 1 or 1.2, who cares? That's, not too often. And it can even run high, over 1.2 for a while.
That's
the idea is wait. Softly. You can then preserve the brain and the kidneys so that when you're elderly, you can still take it. So those are some of the things. We know how to actually use it in a more gentle way. And it's, once a day dosing, and it makes sure you don't ever, if at all possible, have high levels. And Jonathan quoted right there just a minute ago, lower levels. You don't need to slam people over 1.0 all the time.
Yeah, that's certainly true. A lot of people may not realize, too, that it is recommended as a first-line treatment by many guidelines and other entities. It really has fallen into a much lower line therapy. I'm wondering if there aren't also some commercial reasons. We haven't had a branded lithium in many, many years, right? So this is Escalate and Lithium.
Wait a minute. You're telling me that marketing works?
100% I'm saying that. Yeah.
Oh, maybe that's 100%. Part of it.
I
think so.
Counter detailing works. And I think a lot of people were trained, hey, you can put them on a typical monotherapy, a couple of agents, have indications as bipolar maintenance or aripiprazole and olanzapine, and therefore it should be good enough. But I think the clinical data has opened our eyes that when you follow people naturalistically, I mean, there's these large data sets which come out of places like Sweden where you can follow everybody. The rates of treatment failure on a typical monotherapy are extremely high, including a drug like quetiapine, which is one of 2 atypicals, which is an indication for both acute mania as well as bipolar depression. You think it's the perfect drug.
And maintenance.
They'll do worse on it than they do on lithium monotherapy.
That's monotherapy. That's remarkable. Yeah, I remember, and Jonathan, I'm sure you do too, when the articles on valproate, Paul Keck and Sue McElroy, of course, were really at the forefront of this. The valproic acid articles started coming out, and then there was this branded form, and a company got behind it and really started promoting it. But you're right. I think we didn't fully appreciate valproic acid. I don't think we realized the risk associated with the potential benefit here.
Yeah, some of the stuff just came out recently, and I think, that's sad, but it is the way it is that people have come to appreciate some of the harms. And yes, we always knew that there was hyperammonemia and every once in a while some LFT problems. And we knew certainly there was some risk for certain physical anomalies.
Right.
But, I don't think
polycystic ovary, I've seen alopecia. You mentioned tremor and things like that.
Severe problems.
Yes, that's right. Polycystic ovary, though, can be a problem,
Not great, but we felt it was manageable. Yeah. But, over the last 6 years, we've had a number of warnings about valproate, which has essentially been banned in Western Europe.
Well, let's talk about that. It turns out, specifically on March 23rd, 2018, EMA, the European Medicine Agency, issued a bulletin talking about measures to avoid valproate exposure in pregnancy. I mean, not just think about it, but you should avoid it. And then this was followed by a very recent 2023. The UK banned the use of valproate for men and women under age 55. And even more recently, February 19th of this year, the EMA issued a communication about increased risks of neurodevelopmental disorders among offspring of male patients taking valproate, not females, but male partners. What's this going to do to the bipolar disorder landscape here, and how might this affect our use of lithium, Jonathan?
Well, as Steve and I have joked, you can't give valproate to men or women. So I'm not sure you give it maybe pediatric patients, maybe to your dog. Let me tell you some of the numbers just to kind of scare everyone straight out there. Women who take valproate during pregnancy, the rates of fetal valproate syndrome in their children exposed in utero are 30 to 40%. And mostly it's manifested as IQ loss. On average, 8 points, but sometimes much more. And then a fraction of those will also have the physical anomalies as well.
Right, neural tube defects.
To figure out, because everyone recognizes a birth defect, the physical, but the cognitive stuff took time, and you needed large data sets to realize, hey, these people are falling off the curve of intellectual development compared to their peers.
Wow.
So if I wanted to put a woman under 55 on valproate in the UK, I would have to send her to 2 consultants who would both certify she had no other option, and she had to be in a pregnancy prevention program, which is probably going to be a permanent form of birth control, meaning IUD, maybe long-acting injectable hormone. The meal ban, though, was kind of a mystery. I mean, I won't say it's a mystery, Steve, because we knew that valproate did things on histone deacetylase. And you want to explain to people what histone deacetylase is and why messing with it's probably not a good idea?
Yeah, well, your genes turn on and off due to a regulatory process in which the DNA is basically wrapped by basic proteins and called histones. And so when you actually do 2 things to them, they will make your genes start producing proteins or stop producing proteins. And one is histone acetylase, and there's an enzyme called a deacetylase. So if you acetylate things or you methylate things, it changes the expression of genes. Well, I don't know about you, but, changing gene expression messes up fetal development, and it might mess up your own development in the sense of giving you cancer and all sorts of stuff. That hasn't been found yet, but when you're mucking around with genes that are churning on and off, you don't even know which ones they are. Not a good idea. And so this is a histone deacetylase inhibitor, which means you have too many acetylases on your DNA, which changes the expression of genes. And that changes the brain development, and that changes your IQ, and that changes your physical abnormalities and so forth. So that's why it could very well be that valproate will eventually be withdrawn from the market. I doubt whether it would be actually approved today if we, but it's an off-target action. No, and we know that it changes, perhaps GABA levels, and boosting gamma-aminobutyric acid can mean why it works in epilepsy or even migraine, let alone in bipolar. And so this is not how it works. This is how it's toxic. This is an off-target action on histone deacetylase, inhibiting that enzyme, changing gene expression. Not a smart thing to do.
Last but not least, let's tune into episode 156, the Antisocial Personality Disorder Spectrum, Diagnosis and Treatment, with Dr. James Knoll.
We hear the term psychopath being used, and then, of course, in the DSM, we have antisocial disorder and antisocial personality. Are there differences here? What are we talking about?
Yes, Andy, great question. I see how it can be very confusing, particularly to the lay public when they hear these terms thrown about on the news media. But there is a big difference technically between psychopathy and antisocial personality disorder. Whereas antisocial personality disorder is a DSM-5 personality disorder, psychopathy is a research and clinical construct. So whereas ASPD, if you will, focuses on behaviors, antisocial behaviors, psychopathy focuses more on personality traits. So you might could consider or conceive of psychopathy as a smaller subset of ASPD. So about 15% of persons with ASPD will have psychopathy. And psychopathy is considered a more narcissistic, aggressive, and predatory form of ASPD.
Okay, so this would also be the sociopath, in other words.
Sometimes you see that term used interchangeably as well. But again, technically, they're not technically synonymous. Probably the most cited use of the term sociopath comes out of the 1960s when there was significant interest and concern in the social influences of criminal behavior. And so the term sociopath was born. But today, we use mostly the 2 terms, either antisocial personality disorder or psychopathy.
So psychopathy implies criminality or predatory behavior. Is that one way to think of it?
Yes. And the unique thing about psychopathy and its measurement is that it focuses more on the personality traits and styles as opposed to just the behaviors. Mm-hmm. So when you look at the criteria of ASPD, for example, one of the first things is repeatedly performs acts that are grounds for arrest, right? So that's a behavior. Mm-hmm. Or reckless disregard for the safety of others. That's a behavior. Versus psychopathy will consider things like ability to be manipulative and conning, so more personality styles and traits.
And where would a lack of empathy fit in?
Yes, it fits into actually both. So that's one area where there is overlap. And the lack of empathy, particularly when it's observed early in childhood and adolescence, there's a research literature on this, focusing on callous and unemotional traits that makes up part of a conduct disorder. And it's a prognostic sign, if you will, of perhaps the person going on to develop ASPD later in life.
Well, speaking of that, what are some of the risk factors for the development of ASPD?
Certainly, one of them that's been well established is the presence of conduct disorder by age 15. Another thing that there's a large body of research now coming out that's very interesting on adverse childhood experiences, or ACEs. And increasing research is suggesting that the higher number of ACEs one has, it's virtually predictive of the future incarceration or troubles with the law. And then finally, other things that we look for in terms of prognostic factors are a history of childhood abuse and of course, a family history of antisocial behavior.
I see. Do you think
I was
there's
going to
genetics?
ask James, if I could ask, do you catch this or do you inherit this? In other words, is it a disorder that is basically a normal people can get if they have the wrong experiences, or is there a genetic component to it?
Well, that's the money question after all. A great question. So far, there isn't a very crystal clear answer. There are studies that strongly suggest a heritability factor in terms of ASPD. There are even twin studies adopted away and so forth showing some degree of heritability, but it's in the order of the one might expect to see, like from schizophrenia. So it's not super, super high, suggesting that other elements play a role too. And so the prevalence of ACEs in people's lives speak more to the other side of what you were inferring, that someone's social early development and social experiences can certainly play a role in whether someone goes on to develop ASPD.
Yeah, I could almost imagine a genetic predisposition that then is brought out by this. Because I'm thinking there are many people who suffer, well, in the mood disorder field, we call it ELA, early life adversity. And that clearly predicts a depression later on as well, and treatment resistance and things like that. So it sounds like that this is similar. There's people suffer abuse and these adverse experiences, and they can go a number of different ways. And then there are some people who suffer trauma who don't go on to develop problems.
Absolutely. We see that quite a bit. Some people experience the trauma and develop and go a different route, others. And so you're back, I think, to the consideration of baseline of the biopsychosocial model and what plays into what.
Yeah, I'm sure that's true. Is there a higher family history of certain conditions, such as I would imagine substance abuse, or mood disorders, or other things? You mentioned a family history of antisocial, of course.
Yes, for sure. It's important. Perhaps I ought to back up a step and just mention that when you look at ASPD and the ASPD spectrum in general, by the way, people are now looking at these personality disorders as a more of a dimensional character and a dimensional approach. And so just the rest of personality disorders, ASPD is a heterogeneous population, and it produces huge societal and personal costs. And by and large, persons with ASPD have quite a life burden. They live 20 years shorter than others, and they have very high rates of co-occurring disorders, particularly substance use and particularly alcohol use disorders.
Interesting. Fascinating, actually. So it does appear then that there may be certain shared genetics or genetic predispositions, things like that to look for. How about mood disorders? Does that seem to be related or no?
Yes, there is a greater likelihood of depression. And as I mentioned, it's substance use disorders as well. Yeah. In particular, one sees, and it's difficult to tease out the chicken or the egg here, but with women, in terms of gender, women with ASPD, they report high levels of having experienced trauma in their lives. And so all of the downstream psychiatric disorders that one would expect from trauma, one sees in those cases.
The PTSD, for instance.
Indeed. That's quite particularly in corrections and forensics, we see quite a bit of that.
It's interesting you mentioned women. We always think about when we hear antisocial personality or sociopath, I think a man comes to mind, males come to mind. So this can be seen in women, you're saying?
Oh, yes, indeed. It could be interesting to look into the future, and because, we're constantly undergoing sociocultural change, and today's day and age is no exception. So it'd be interesting to see how this develops into the future. But at least up until now, there's about a 3-to-1 ratio of men to women in terms of ASPD. So about 6% in men, about 2% in women. If you look overall, the general population, what's the incidence? About 3 to 4% in the general population. And
but 6% of men, that's high. That strikes me as quite high.
Yes. And so in corrections, though, it's much higher, of course. Now, some people will say, isn't everybody de facto antisocial personality disorder in corrections? And the answer is no.
No, I wouldn't think so, yeah.
Yeah, only about 50 to 60% of people meet criteria for ASPD. But again, higher in men than women. This 3-to-1 ratio is still represented. The difference, though, in corrections for women is that they report more frequent childhood emotional neglect, abuse, adverse events, and less violent, physically violent antisocial behavior than the men do.
I see. Steve, are we criminalizing here a mental illness? I'm thinking we're putting all these people in jail.
If they commit crimes as opposed to just having a hallucination isn't a crime, I think that it's interesting. I could ask James this question about the criminality. Are the dumb ASPDs in prison and the smart ones in the Senate and in CEO suites?
Dr. Stahl, you're onto something here as usual. The flip answer is essentially yes. That's jokingly referred to in the field as unsuccessful versus a successful psychopath. And the judgment has been that we've studied much more the unsuccessful psychopath. But more recently, interestingly, the creator of the psychopathy checklist, Dr. Robert Hare, has begun to turn his focus on white-collar criminals. And some of the early findings are very interesting. That he found that there are higher rates of psychopathy in these high-level executive positions than we had previously realized. But of course, probably to us, that's not a great revelation.
Yeah, I don't think it's actually that surprising, but that's because we're familiar with this condition.
Isn't there that best-selling book by that New York Times author? I can't really remember him. He read the psychopathy test, and he memorized the Hare criteria for this, and he would interview CEOs and various people, even casually on an elevator, and try to diagnose psychopathy surreptitiously, and found quite a bit of it. So I think there's something to be said about that.
Yes, I'm not getting any money or anything for this or plugging a book, but you're speaking of John Ronson, and he published a book called The Psychopath Test that is very interesting. It's easy to listen to. It's not too academic, but you do learn a lot about psychopathy and the field.
Yeah, I think this might be a little surprising to some of the people listening, to some of our audience today. I think, again, there's a certain stereotype. It's a male person in jail is a stereotype, but certainly not true. Now,
could I actually ask James, if I may interject, Andy, what about the possibility that there's pathology in the amygdala such that you're underreacted? Now, whether that's trained, acquired, or genetic, but the idea that you're not hot-blooded, but that you don't react, and that there's something wrong with your amygdala reactivity in sociopathy, psychopathy, ASPD. What do you think of that?
Yes, that is what, at this point, some of the best research suggests. that one kind of, I guess, pejorative term or lay term is that they have dark amygdalas, that they're underreactive, and that, of course, the amygdala being responsible for, among other things, our fear response and emotional processing and our moral emotion and reasoning. And so some sophisticated, nice studies have been done with brain imaging using PET scans and functional MRI. And they'll show psychopaths emotionally laden words while they're in the scanner. And they'll compare them to controls. And whereas controls amygdalas will show great activity, psychopaths much less so, much less activity in the amygdala. And so it's been hypothesized then that psychopaths deal with emotional processing in a more cool, cerebral fashion as opposed to an emotional fashion.
Wow, that is fascinating. And it certainly makes sense. Makes a lot of sense that there'd be physiologic correlates to this to some degree. Are there other physiological correlates? I mean, do they not dilate, have the same sympathetic outflow, same skin reactivity and things like that?
Yeah, that's exactly right. Other areas before you leave the brain that have been singled out and looked at as having possibly some dysfunction, particularly in psychopaths, include the orbitofrontal cortex and ventromedial prefrontal cortex, which probably is not surprising to most. Those things that put on the brakes. And then in terms of other physiological findings, there's this long-standing finding of autonomic underarousal.
Yeah.
And also frontal cortical underarousal. Beyond that, there's also been some studies suggesting perhaps lower levels of serotonin and higher levels of testosterone, but those tend to have some type of methodological issues.
I can imagine at least a subset of these folks have too much testosterone. That would be associated with some of these behaviors, but I don't know that's a requirement.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIGlobal.com.